Hi students, welcome back. Good evening. And we are going to do some discussions about a few topics which are not under any particular heading in the obstetrics chapters, but those are the biggest headaches we have sometimes in the labor rooms. So these topics can easily come in your entrance exams, but they are also the ones which we keep asking you when you're giving your final MBBS vivas. These come there as well. So let us see how many of them we can do today and how many of you can understand. I'll be looking forward to your questions on the YouTube. So keep yourself busy with the questions so that we can make good use of these sessions which we're having. A lot of you are writing the exams on the 17th. I hope you guys are also here. Otherwise, if you're seeing this a little later, you can keep punching onto the chat and we can always catch up later also. So guys, we are talking about the fourth prof Farre sessions, but these are important even for the people who are writing the exams. So yes, one of the first topics which I feel it is important and often seen as a complication in the labor room is the umbilical cord prolapse. And before I say anything about this topic, remember one thing: moment you see a prolapse, all you interns especially, moment you see a prolapse, do not try to hold the cord and push it back inside. That's one instinctive reflex a lot of us have. I've also held the umbilical cord once and I got fired by my senior resident at that moment. Don't touch the cord wedge, you're going to kill the baby. That's what was told to me. So do not try to push the cord, okay? Try to push the presenting part up. I'm telling you, I have not told you anything about umbilical cord prolapse. Try to put the presenting part up, push it up. Do not push the cord, okay? We don't want the prolapse cord to be compressed by the presenting part. That's what I wanted to impress up front. So umbilical cord prolapse, the incidence is less than 1% of all the pregnancies. It's a serious labor complication and there's a very high chance of fetal morbidity and even mortality. So when we see umbilical cord prolapse, it can be seen mostly because of the non-cephalic presentations. That means if we have a breach, we have a transverse lie, oblique lie, or an unstable lie. These are the conditions where we'll see more cord prolapse. Remember, cord prolapse can also happen with the cephalic presentations, and cephalic presentations are way too many. Most fetuses are in cephalic presentation. So actually, if you see the number of cord prolapse, you'll see more with cephalic presentations. But yes, we are asking you which type of conditions will predispose more to cord prolapse. So that's why it is predisposed by breach, transverse lie, oblique lie, and an unstable lie. All of these it will be predisposed more. So whenever we have such patients, we admit them a little early. We tell them that you may end up in a cord prolapse, and if you rupture your bag of membranes at home, so it's better that you're in the hospital. We admit them very early in the moment they touch term, we admit them in the hospital. So yes, can present as a overt or an obvious cord prolapse, that the patient was in labor, the bag ruptured and the cord came out. That is what is the most common presentation. We generally see the cord is outside. Sometimes we put our fingers into the vagina. We put our fingers into the vagina and feel the cord next to the head or to the breech, whatever here. So you can see the cord next to the presenting part. That is the second type of presentation, the occult prolapse, or sometimes there can be a cord presentation. What is the presentation? Part of the fetus in the lower segment is known as the presentation. So, if the head is in the lower segment, we say it's a cephalic presentation. If the breech is in the lower segment, we say breech presentation. But sometimes the cord is the lowest part in the uterus. It is just above the internal os. So then we say it is a cord presentation or a funic presentation, like we say. All right, so these can be the presentations of this. Now, prevention. Whenever you have a non-cephalic presentation, you admit early, okay? Offer admission at 37 weeks of gestation and explain the patient that there is a risk of cord prolapse. But please remember, avoid an artificial rupture of membranes and all those conditions which I told you. Breech, transverse lie, high head, unengaged head, all of these conditions don't do a artificial rupture of membranes. You will make the liquor come out and that sudden gush of fluid will give a sudden decompression, will give a traction onto the cord also, and that will come out of the vagina. So funic presentation, high presenting part, non-fixed presenting part. These are the conditions where you will make the patient not have a artificial rupture of membranes. So what is the management? Always when you are in a situation of emergency, always call for help. Why? Because you are not supposed to leave the woman. You know what's happening? You are trying to put your hand inside the vagina and push the presenting part up. So you are stuck with the patient. So who is going to do the other things? So you will call for help, and you are going to ask somebody to get the OT ready, because this patient has to be managed in the operation theatre. So you will always need somebody to help, and you need somebody to tell the relatives also that there's an emergency. So your team should always be there to help you. Call for help. Prepare for immediate delivery in the operation theatre by a cesarean section. There is nothing else you can do but a cesarean section. There are some exceptions, I'll tell you, but mostly prepare for a delivery by cesarean section. But yes, if the cervix is fully dilated, that can be a situation sometimes, that the patient is a fully dilated cervix, especially in multigravidas. Then in a fully dilated cervix, the cord can slip out. So that time you may have an advantage that, okay, it's a fully dilated cervix and it's a cephalic presentation, maybe I can put a forceps and take the baby out. By the time you prepare for a cesarean, you can do a faster forceps delivery. So yes, that is one exception. Otherwise, if the cervix is undilated, then you cannot wait for a normal delivery. You have to rush the patient to the OT and do a cesarean section. And do not touch the cord. What I told you in the beginning of the chapter, do not touch the cord. You will promote a vasospasm, and do not try to manually push the cord above the presenting part. All of this is going to cause a vasospasm, and that is going to kill the baby. I'm telling you that very, very strongly. Do not touch the cord. Try to push the part. So that is what those are what are the Royal College guidelines. I'll just tell you those guidelines. This is from the RCOG, and credit to them. And these guidelines, remember, I'm just trying to tell you, because none of the books are clearly giving it, but if you see the Royal College guidelines, mostly they'll give us the good messages which we must follow into our labor rooms. So yes, what are they telling us? The preparations are made for an immediate birth in the theatre, not in the labor room, and there is insufficient data to evaluate manual replacement of the prolapse cord. So no touching the cord and pushing it up inside. So to prevent vasospasm, there should be minimal handling of the loops of the cord. And to prevent cord compression, it is recommended that the presenting part be elevated either manually or by filling the urinary bladder. What I told you, push the cord up. Push the presenting part up. You put your hand in the vagina and push the head up, or if it is a breech, push it up so that it doesn't press on the umbilical cord. What else you can do? You can fill the bladder. You can put a catheter in the bladder and fill normal saline. So when the bladder gets filled up, that filled up bladder will prevent the presenting part to get into the pelvis, and that will not press, the head will not press, or the breech will not press on the cord. So keep the presenting part up by filling up the bladder. That's what is the best management, right? But what else we can do? We can keep the patient in a lateral position like this. Suppose she is lying down like this, the compression will be more. So when you keep the patient on the side, the weight of the baby comes on the side. Or what you can do, you can keep the patient in a head low position. We call it a Trendelenburg position, like that. All of that I'm showing you here. So yes, what else we can do, and what all other things which are given by the Royal College guidelines? One can attempt to push the presenting part, not the cord. The presenting part is pushed upwards. Reduce the obliteration of the umbilical cord. We can give a knee chest position. The patient is on her knees and on the knee chest position, like that. I'll show you the position like this. She's on a knee chest position, so that the weight of the baby goes towards the upper part of the mother, and it is the head or the breech is not presenting on the prolapsed umbilical cord. This is the knee chest position, and the weight of the baby also comes to the maternal abdomen. So this position also helps. Or a lateral position and a head low position, the Trendelenburg position, will also help. So one can also fill the bladder, and we can give a tocolytic injection so that the contraction of the uterus is not pressing the presenting part into the pelvis. So we can give a relaxation of the uterus also. So before that, before I get into shoulder dystocia, let me see what you're asking. Hi, Dr. Lulu, how are you? And great to see you here. And all my good friends. Dr. Malika is here. Knee chest position. Yes, that's correct. All right, guys. So now that there are not many questions here, let us get into the other discussions about the shoulder dystocia. Now, shoulder dystocia is seen in 1% of all the deliveries, and it is that dreaded complication which is there in bigger babies which are present in diabetic mothers. So if you see the head of the baby when it comes out, whenever the head of the baby comes out, what do we do next? We try to take out the shoulder. So we hold the head and give a slight downward traction. We give a downward traction so that the shoulder delivers from the pubic symphysis. So when we are doing this, when we're trying to take the when the head is out and trying to take the shoulder out, you give a downward tug like this and the anterior shoulder comes out. So what are we always worried about? Like when the head of the baby comes out, we know the delivery will complete. But sometimes what happens, although the broadest part of the baby is the biparietal diameter, see the head and the biparietal diameter. This is the broadest part of the baby. Baby's broadest part is the biparietal diameter. Look, if you look at an adult like me, then the broadest part of an adult are the shoulders. But in the fetus, the broadest part is the biparietal diameter. Moment the head comes out, we say, okay, this delivery will complete. But sometimes what happens, the shoulders are very big, like in case of a baby of a diabetic mother. So the head comes out, but the shoulders get stuck. And you go on trying to pull out, the shoulder. And if you do all that, that is going to cause stretching of the brachial plexus and the nerve injuries can happen. That's why do not go on stretching the neck, because you can cause the injury of the brachial plexus. So remember, when we do this management of shoulder dystocia, there are some steps which you should understand, but some introduction first. That anything that comes in the way of a delivery is known as dystocia. That is, if the head comes out and the shoulder is stuck and the delivery is not completing, we say it's a shoulder dystocia. Sometimes the cervix doesn't dilate, cervical dystocia. So anything which comes in the way of progress of labor, that is what is known as dystocia. So shoulder dystocia is diagnosed when the delivery of the shoulder doesn't happen after 60 seconds have passed after the delivery of the head. So usually what happens, once the head comes out, the shoulder comes out in 20 to 25 seconds usually. But if it takes more than 60 seconds, we say it is shoulder dystocia, and that can cause significant neonatal morbidity and even mortality, because you're going on pulling and you may cause some fractures of the spine of the baby also, because sometimes you get very desperate and use a lot of force. And if you're using too much of force and your body weight to pull the head of the baby, then you already as much as made the baby hypoxic for the rest of his life, having lifelong sequelae of hypoxic brain damage. So do not use too much of force in obstetrics. If you're anywhere you're applying too much of force, that means there is something wrong in the methods which you are using. So that's why I keep saying that even if you sometimes apply forceps is all about the right technique. So forceps is not forceps. You're not applying, if you're applying too much of force to take a baby out, then your application is not good. Similarly, if you're trying to take out the shoulder and it's not coming out, that means something is wrong. Do not use too much of force. So obstetrics is a lot of physical involvement, but it is not brute force. It is smart physical involvement, not brute energy to try to pull out babies. All right. Rest. Shoulder dystocia, 1% of our deliveries. So it is associated with large babies, post-term pregnancies, diabetic mothers, and also with anencephaly babies. Now, why does anencephaly cause shoulder dystocia? A lot of you end up saying, so there is no head, so the head comes out, half of the head, it comes out easily and the shoulders get stuck. Wrong answer. Anencephaly, what happens that since there's no fetal head and there's no brain of the baby, so the fetal pituitary is absent. So fetal oxytocin is not made. So the fetal oxytocin contribution to the net amount of oxytocin during term, maternal oxytocin, fetal oxytocin together is responsible for the initiation of parturition. If that oxytocin is less because of absence of the fetal pituitary, then the pregnancy tends to go post-term. So any baby goes post-term, the body size will increase. That's why the baby is big in a case of anencephaly, and that big baby with big shoulders will have shoulder dystocia, not because the head is missing. All right, it's basically the large baby which is the cause of shoulder dystocia. Okay, that's what I've written here for your notes purpose. Let's move on and see what are the complications. Pulling the head too much can cause the Erb's paralysis, the complete paralysis like I told you, and clavicular fractures. Management, again, call for help, because you are busy with the lady. You want to make sure that you are going to get the shoulder out. You are throwing your orders to your team and your nurses and your residents and your associate doctors, and somebody is getting the OT ready. So call for help first, and then first thing, remember, flex the hip joint. Always remember, any woman who delivers, you're making her flex the hip joint. Wait, let me show that to you. Look, any woman who is delivering, don't you tell her that please hold your legs, pull your legs towards yourself, raise your head, clench your teeth, look at your umbilicus, raise your head, look at your umbilicus and push. Don't we tell that to any woman? So that's what we're telling to this woman also, that you keep pushing. But now what we do, we hyperflex the hip joint. When you hyperflex, see this hip joint here, if you flex it more than 90 degrees. So this is what came in a MCA exam once. How much is the flexion of the hip joint? More than what is required in a case of shoulder dystocia. So hyperflex the hip joint. So when you're hyperflexing the hip joint and abduction of the hip joint, what does it do? It straightens the sacrum. You know, this is the sacrum like this, and if you flex the hip joint, if you do the flexion of the hip joint, see the sacrum, this is the sacrum here, the sacrum gets straightened in relation to the maternal spine, and it decreases the angle of the pelvic inclination also. So that's why it is easier for the anti-shoulder to come out. So McRoberts maneuver, remember, is the first thing to do. Yes, do not think of suprapubic pressure as the first thing. It is instinctive for all of us to flex the hip joint, and that flexion of the hip joint, mostly the McRoberts maneuver, which it is called, is enough. But yes, if that doesn't work, then we can do the suprapubic pressure. So I've got you this picture from an American journal. Here you are seeing that the doctor is holding the foot of the woman and pressing it upwards. So that pressing the leg upwards is going to cause the flexion of the hip joint. So that is number one. And number two is the suprapubic pressure. So if you give a thump, if you give a suprapubic pressure, you know, that pressure on the shoulder, the head is out, shoulder is stuck, you give a thump, the shoulder comes out. So when the shoulder comes out, that is what is the Rubin's maneuver. Rubin's. So this Rubin has, there are two maneuvers of Rubin. So if you really want to call it Rubin's, you must call it the first method of Rubin. There's another Rubin's method, but we are not going to all the maneuvers which are mentioned in literature, because they are, you know, some of them are not very fruitful also. So suprapubic pressure you use, and that's what is going to help. And if that doesn't work, then what are we going to do? We are going to turn the baby. We are going to turn the baby like a corkscrew. So what is that? We put a hand into the vagina and go to the anterior aspect. Don't read anything there. I'll give you the notes. Look here. Put your fingers on the anterior aspect of the posterior shoulder and turn the baby like that. So obviously you're going to use two hands. You're going to put your fingers here, turn the baby like this. While turning the baby, you're pulling the baby down also. So when you turn the baby, this shoulder comes under the pubic symphysis. So the posterior shoulder comes under the pubic symphysis, and this is delivered first. Okay, so see here, the baby is turned and this posterior shoulder is now under the pubic symphysis. See, this is the pubic symphysis here, and the posterior shoulder has come out. So turn the baby like this, like a corkscrew. So I'll try to show that here also. Look here, if you imagine my middle three fingers as the head and these as the shoulders. So the baby is like this, and the head has come out, but the shoulder is stuck. See, my thumb I'm showing you as a shoulder, it is stuck. So what do? You turn the baby and deliver this posterior shoulder from the pubic symphysis. So what do? From under the pubic symphysis, the posterior shoulder comes out. When you turn the baby, see, when you turn the baby, this posterior shoulder comes out, and then you turn the baby again, this shoulder comes out. So the anterior shoulder is not delivered first, the posterior shoulder is delivered. You turn the baby, the posterior shoulder comes out, then again you turn the baby, this shoulder comes out. So both the shoulders are delivered after rotating the baby and pulling the baby a little, with the pulling downwards with a little bit of traction. So that is the corkscrew maneuver. Pushing can lead to prolapse. Which pushing, my dear? The suprapubic pressure? No, it does not. Mother pushing? No, does not. If you push in a fully dilated cervix, there will be never a prolapse. Prolapse happens because of badly conducted labor. So don't get worried. If the cervix is fully dilated and the mother is pushing the baby, she's using her abdominal muscles to contract the uterus, and that is going to push the baby out from a dilated cervix, that is never going to cause prolapse. If the cervix is not dilated and then you tell the mother to push, early bearing down, that causes prolapse. No, pushing never causes prolapse. Badly conducted labor, untrained people, those conducting delivery in the villages, they'll go on pushing the baby. The fundal pressure. Fundal pressure is not obstetrics. No, fundal pressure is not obstetrics. We don't give fundal pressure. Yes, you must have seen it in all your labor rooms. All you interns, I'm sure you are screaming at me, sir, sab log karte hain, sir. And you finally have students who've gone to the labor room. Sir, everybody does it. No, please don't do it. It is not obstetrics. Definitely, if you've done it, please don't say it in the exam. My final year MBBS students, if you've seen it and if you've done it, you're trying to help in the labor room, all you boys will go and help the nurses because they are too tired, and you'll go and say, okay, fine, I'll do the fundal pressure because you have more muscles. No, fundal pressure is not obstetrics. A lot of cesareans also happen like that. Yes. Even day before yesterday, I was getting upset with my resident. I was in the OT and I was saying it's been a while since I did a cesarean. So I went inside to the OT and I saw they had made an incision on the uterus and the baby's head was a little floating. So somebody was going on, one PG was going on pressing the abdomen in a cesarean to get the head out. No, fundal pressure is not given. You can cause bruising on the uterus. You can tear a uterus if it is a multiparous uterus. No. Good. Pushing is not related to prolapse. Good, somebody has corrected that. So can pushing cause, you have touched a raw nerve for me, okay? Never do fundal pressure. So yes, pushing, the giving a suprapubic thump, that can disengage the shoulder. That is fine. Okay, fine. Let's get back to work. We are talking about the Wood Corkscrew maneuver. So what I told you, I have just written here. You can freeze this and read the notes later on. Now, if this does not work, then the next thing we can do is the Gaskin's all four maneuver. Look here, all four again. All four means in Hindi we say, no, charo khane chit, with hands and legs. See, on the floor. Charo khane chit, all four maneuver. So this position, if you do, can you see the weight of the baby has now gone? This is a case of shoulder dystocia. Now the weight of the baby has gone to the metal abdomen. So the posterior shoulder will be delivered. Can you see this here? I have marked it here for you. See, the posterior shoulder will deliver from the posterior soft vagina. So the posterior shoulder is delivered first. So you will get more space and then the anterior shoulder will come out easily. So Gaskin's all four maneuver, that is also one method. And if nothing works, then the final resort to Javanelli's restitution. Basically what happens, see, the head has come out like this. So there is external rotation after delivery of the head. You hold the head and correct the rotation and then push the head back inside the pelvis and then do a cesarean section to take the baby out. Easier said than done, please guys. This is a big baby which has come out after 15-16 hours of labor. The mother is going on straining. The uterus is going on contracting and it's a big head and you're trying to push the head back against the contraction. You will give tocolysis, you will give injection of terbutaline to relax the uterus, yes. But by the time you finish and do a cesarean section, 70% babies are already lost by that time. This is the last desperate, don't say, why didn't you do this first, sir? No. This is the last desperate maneuver to save the baby. And you will save probably around 30-40% babies only by Javanelli's restitution. And the ones who survive also may have some lifelong sequelae. So yes, but the few which you can save, for them it is worth it. Right. Let's move on and see something else. Precipitate labor. Before that, what are you guys asking me? Okay, fine. You're not asking me anything. So for the timing, you're looking at things for the time being. Okay, fine. Even if you're seeing it later, you can always remember to message me on the same forum, and my PW team will always get back to me, and we will keep doing the answering. Right. So what is precipitate labor? Precipitate. Something happened very fast. Precipitated. So precipitate labor is when the time taken from the onset of contraction to the delivery of baby is less than 3 hours. I've seen deliveries happening within 1 hour in multigravitors. They've gone into labor. By the time I go and write my notes and see the other patients and come back, this woman is already pushing the baby out. It has happened so many times in multigravitors. So yes, it is less than 3 hours and it is seen in less than 3% of all deliveries associated with PIH and abruption. Wait a minute. PIH and abruption, the delivery happens fast. What did I say? PIH and abruption, delivery happens fast. So in abruption, you can do normal delivery. Guys, I'm going off topic for a minute now. Do not say abruption, you'll do a cesarean section. Lot of babies with abruptions are not even having any distress. So there is an abruption and there is no distress. You can do a normal delivery, and the delivery is actually faster in abruption as compared to normal deliveries. Induced labor, she'll deliver fast. Abruption by itself is never an indication of cesarean section. Abruption with a distress, go ahead and do a cesarean section. I'm telling you to do a cesarean section at that time because the distress becomes the indication. Don't say abruption, I'll do delivery. Some of my teachers will get angry if I say that, if God forbid, if they listen to this even on a recording later on, that which said abruption with cesarean straight away. Nonsense. Abruption, you have to deliver normally. If she's having distress, the baby is having distress, or the mother is not, she's having added complications, mother is getting sick, then maybe you can take an exception, do a cesarean section. But by itself, abruption not a indication of cesarean. I've told that 3 times. Get back to the topic of precipitate labor. It is associated with conditions like abruption and PIH, and there is less resistance from the soft pelvic structures, and there are strong uterine contractions, and some women have less pain perception. So that is what is the cause of precipitate labor. And complications can be because the sudden expulsion of the baby, vaginal vulval lacerations, amniotic fluid embolism, and PPH. So you can, if you see that the things are happening very fast, you can try some injections of terbutaline, tocolytics, terbutaline subcutaneously, 0.25 milligrams can be tried. Inhalation anesthetics like the halothane can be given to relax the uterus, and stopping the oxytocin infusion if you see things are happening very fast. Amniotic fluid embolism, another major disaster. Upfront, let me tell you, sometimes, before I give you any introduction here, don't read anything. I just want to tell you something now. You've delivered a woman, everything has gone up fine, and the baby has been, after all the formalities, you have cut the umbilical cord after 60 seconds of waiting, delayed cord clamping, then the baby has been resuscitated and cleaned by the nurse, and the baby is now given to the mother, she is nursing the baby, and you're suturing the episiotomy. Suddenly the mother leaves the baby, and the baby is almost about to fall. Somebody holds the baby, and then the mother gets suddenly unconscious, and you see there is sudden tachycardia, then loss of blood pressure, she collapses and she dies. I mean, you are like, what happened to her? Why did she get so sick? Because there is no PPH. You've not done any inversion. Nothing is wrong with the patient. The delivery was perfect. Mother suddenly dies. That is what is amniotic fluid embolism. You don't know what went wrong. So this is the reason amniotic fluid embolism is that disaster which I've seen so many times in my life, and most of the time they have died. Yes, it's not because I'm a bad doctor, but it's just that this is a very bad disease to manage. All of us have tried. Occasionally a patient has survived. So this is what is the problem with amniotic fluid embolism. So yes, incidence is not so high. It is 5 to 10 deliveries every 1 lakh deliveries, and it's an anaphylactoid reaction. It's basically the amniotic fluid which triggers the tissue factor and starts the coagulation cascade, ending up in DIC. Then the fetal squams also trigger the endothelin, which causes the vasospasm. Amniotic membranes, they release the phosphatidylserine. That phosphatidylserine will also contribute to the pathology, and there is that sudden bronchospasm, respiratory distress, and of course the right heart is getting totally loaded with the blood which is coming, but the lung is not working, so the left heart is trying to compensate, and the left heart is getting so much of contraction, is doing so much of contraction to compensate. It's basically contracted but empty left heart. So that's what happens. Mother goes into cardiorespiratory collapse and dies. So I'll just try to show you the chain of events. Phase 1 is the rapid respiratory failure and hypoxia because the bronchospasm, like I told you, and then a totally filled up right ventricle, dilated right ventricle, which is becoming akinetic, and then there is a right side heart failure. Now to compensate for that, there is a vigorously contracting left ventricle that becomes very small because there is hardly any blood coming from the lung. It is small and the cavity is obliterated. There is loss of systemic vascular resistance, and then there's a cardiovascular collapse, and the patient dies. So yes, we can try and manage this by giving some methods, but mostly we are not able to save because of that sudden onset of pathology. So phase 2 is the consumptive coagulopathy, and phase 3 is the multi-organ dysfunction. The lungs, brain, the kidneys, the hepatic injuries occur within 30 minutes, and more than 50% women, yes, I would say more than 90% women in my practical example, but literature says more than 50% women will die with amniotic fluid embolism. So yes, we can try. We will obviously try. We will not give up and hope that we can save some patients. So we can try rushing IV fluids, and IV fluids can be the crystalloids like sodium chloride, and then you can give the colloids like starch. We call it the hydroxyethyl starch, or we simply call it the hexa starch. Dextran, the volume expanders. Then we can give the steroids for the the reduction of the acute phase reactions. So yes, we can give the high dose hydrocortisone, 100 milligrams to 200 milligrams we can give intravenously, and then we can give the bronchodilators like aminophylline and a whole lot of blood products, fresh frozen plasma, platelets, cryoprecipitate, whole blood, Sometimes we keep demanding for fresh blood if it is available in the blood bank. Yes, hoping that we can save some patients sometimes. Yes. Why patient type? Because Sutta Prasanta Pasamanta. Okay, Sutta Pasamanta. Okay, I'll call you Sutta, right? So yes, it is because the patient is having that sudden cardiovascular collapse, because see, the lung is into a very severe bronchospasm because of the allergy, and it is not doing its function. So the right heart is not able to push any blood into the left. Right heart is not able to push any blood into the lung, and the lung is not able to have so much of blood because the lung is not working anymore, and that's why the left heart doesn't get any blood from the lung, and that's why there is hardly any blood to pump in the body, and that's why it causes a cardiovascular prolapse. That's what I told you earlier also. Okay, fine. I told you the risk factor just now, the previous topic. Sudden fast delivery can cause, but it can happen without that also. Multigravidas generally tend to have more chances, but we have seen it in primary gravidas as well. But if it's a very rapid progress of labor and a prolonged rupture of membranes for a long time, if the ruptures of membranes has happened, all of these are purported predispositions, but most of the times it happens without anything as a predisposing cause. Generally, fast progress of labor is associated. Right, let's get into obstructed labor. There is no progress of labor in spite of good uterine contractions. Basically, it means the uterus is contracting very hard to push the head inside the pelvis and dilate the cervix and cause the descent of the head, but the head is too big to enter the pelvis, or it has entered but it is too big to go through the mid pelvis. So when the progress is not happening in spite of good uterine contractions, we say it is obstructed labor. Right, that's what I've written here. Neglected cephalopelvic disproportion, large baby, malpresentations like transversalized shoulder presentation, neglected brow presentation, and then malposition like occipito-posterior and contracted pelvis. These can predispose to obstructed labor. Now, there is a very simple assessment if you are having the patient in the labor room. What happens? This obstructed labor causes more problems because obstruction is happening to a patient who is in a village. And basically what happens, that the DI thinks that she can deliver anybody properly. She has delivered a lot of primary gravidas. She has no idea that this is a third gravida, and third gravida should deliver normally because she's had 2 deliveries before. So the third gravida will deliver easily in the village, but third gravida will have a bigger baby than a primary gravida. That's a very common association. Larger babies in multiparous women, and that larger baby, in spite of a woman having 2 normal deliveries, this time the baby is really big and the mother has developed diabetes this time, and that big baby does not go through the pelvis, and the DI thinks this mother is not pushing properly, so she's going to go on trying to give a fundal pressure, and that can even cause a rupture of uterus. So this obstructed labor, please remember, can cause a rupture uterus if it is especially in the village. So if the woman is having obstructed labor in the labor room, you will be able to see the signs, and you will definitely not get to see the complications of obstructed labor because you are a good doctor. If it is in the village, then drastic complications of obstructed labor can happen. So let us see what can happen. There is a failure of descent and dilatation of the cervix, and there can be hematuria. Now, why does hematuria happen? Because see, this head, this big head, the pubic symphysis, this is the bladder here, the pink thing which I'm showing you, and this is the pubic symphysis here. So this is the anterior part of the mother, and that is the posterior part. This is the rectum here. So what is happening? The head is pressing on the bladder, which is getting pressed against the pubic symphysis, and this bladder is getting stretched. So the venous plexus of the bladder gets torn. The base of the bladder has a lot of rich venous plexus that gets stretched, and then the mother starts to have hematuria. That's one sign that there could be an obstruction. That's what I've written here. And then there could be maternal exhaustion, tachycardia, and dehydration. And because the head getting stuck, the venous return reduces. So there will be a uniform pelvic edema. You'll see the vulval edema. The vulva will be so edematous. You'll see looking like, big lips of vulva. They are so swollen sometimes. They look as if they're full of fluids and jelly like. There you'll see the vulva. Okay, and then there'll be fetal distress and even fetal death. So that is obstructed labor. Management of obstructed labor, there's only one thing, and that is cesarean section. Please do not say obstructed labor, why can't you put forceps? I was asked this question in the class and I was thinking, you're not understanding what is happening. The head is not able to get inside the pelvis in the first place. So if the head is not in the pelvis, how will you put forceps? If it has gone into the pelvis and stuck at the mid pelvis, how will you put forceps? So always remember, forceps and vacuum in modern obstetrics are applied only after +2 and below. +2 station and below, that means all obstruction has been ruled out. So please, all instrumentation in modern obstetrics is +2 station and below. If you keep that in mind, you'll never say that forceps can be used for obstructed labor. Come on, the head is not coming to the pelvis. There's no question of doing instrumental delivery. So please don't say. So we always say cesarean section. Now, when we say cesarean section, I mean to say even for dead fetuses. If the baby dies because of obstruction, dehydration, prolonged labor, even if the baby is dead, I will say do a cesarean section, and this is what is followed now. Obstructed labor, baby is dead, don't try to do destructive operations. Don't try to put instrument inside and crush the head and, collapse the head and collapse all of that. My seniors, my professors have all done them, and they were experienced people. But we were taught, I'm talking about 1996 when I got into my post-graduation in JIPMA, and I was taught, let me tell you that. I have seen many of them. But remember that when I gave my MD exam, when I gave in 1999, my MD exam and my DNB exam also the same year, I was never asked. Both the exams, I was never asked destructive operations. I've not seen them being asked. I keep going for a few DNB exams sometimes. It has never been asked because it is supposed to cause a lot of injuries to the mother. So destructive operations are not even taught these days. It's better to do a safe cesarean than a. So at your level, these are debatable things in postgraduate level. But at your level, guys, please, no destructive operations. And if they're asking you destructive operations in your MBBS exams, it's unfair. They will not ask you. I guarantee you they'll not ask you that. Okay, just somebody listens to me and asks this to trouble you, then bad luck, but they're not going to ask you. So please, if there's a dead baby, again you have to do a cesarean section. Right. So let's move on. That, remember, if there is a case of obstructed labor, this head can be pressing on the pubic symphysis, and if it is especially a neglected obstructed labor. In a case of neglected obstructed labor, the head of the baby can be pressing against the pubic symphysis. In that process, it can also press the bladder neck against the pubic symphysis. Now, when this bladder neck is compressed against the pubic symphysis, it can cause ischemic. It can cause ischemic necrosis of the bladder neck. And that ischemic necrosis on the bladder neck can make the patient present with a vesicovaginal fistula. That's what is very important, because see, after delivery, see this vaginal part and this bladder neck, this has got ischemic. So in 5 to 7 days, 5 to 7 ischemic area will slough off, and when that sloughs off, she will come to you with dribbling of urine. So if there's a case of obstructed labor and she's in your hospital, you've recognized obstructed labor and you've done a cesarean section and you saved the patient, you saved the baby and you saved the patient, but you have seen the patient, you're a doctor, then make sure, if you have diagnosed a case of obstructed labor, you will catheterize the woman so that the bladder neck doesn't get stretched. You'll give the bladder neck a chance of healing. So catheterize into 2 weeks. For 14 days, we catheterize. You have done a cesarean, and after cesarean, 5-6 days later, you can send the patient home. He comes for suture removal after 1 week. So normally nowadays, 3rd, 4th day, we are sending patients home. They come for, mostly we are putting subcuticular sutures, so they don't come for removal also. But we keep the catheter with her. She goes home with the catheter stuck to her leg. We always fix a catheter. Interns, guys, don't let a catheter hang in a woman. Okay. And if you're making a woman catheterize, make sure the catheter is fixed to the thigh. And if the catheter is hanging and I am your consultant, then you're going to be marked absent for that day. We get strict sometimes that way. All right, we're not so strict. I'm just scaring you. So please remember, all catheters have to be fixed, and those catheters will give the rest to the bladder so that the neck of the bladder gets healed. All right, remember that. Fine. What are the complications because of this patient with obstructed labor? Chorioamnionitis, pupil sepsis, and rupture uterus can happen, and because that the woman can go into shock. They can be bladder and rectal injuries, like I told you. They can be a vesicovaginal fistula. They can be rectovaginal fistulas also. These are the late complications which can present, and they can be stress urinary incontinence because of the ligamentous support which gets spoiled because of this prolonged labor with obstructed labor. Right, and fetal complications, like I told you, stillbirth, baby is born dead, hypoxic brain damage, lifelong sequelae, and neonatal death. All of these can happen because of case of a obstructed labor. What is your doubt, Sutta Prasanta? When I'm in the middle of a topic, obviously I won't be. I'll see it at the end of a topic, my friend, or even if I'm doing a segment. Okay, Sutta Prasanta, don't get upset with me. Okay, so obstructed labor, why happen? I already told you. We discussed. Okay, yes, obstructed labor. Acha, you asked me earlier about why amniotic fluid embolism happened. Then, so the person, I mean, I was in the, you were in the class. Yes, we already discussed. Obstructed labor happens because of large baby and malpresentation, malpositions. Okay, the slide is there. You can rewind and see. Okay, and then what is the doubt? What else is it out? Hematuria. Hematuria because the bladder neck gets stretched because of the head. Okay, maybe I can show that to you. That picture was there. You see here, the head of the baby. This head of the baby is pressing on the bladder neck, bladder base rather. This bladder base is getting stretched because of the large head. So when the bladder base gets stretched, bladder base has a lot of big veins. See the vesical venous plexus, this bladder plexus here. So that bladder plexus, these veins get stretched, and that's why there is, don't say rupture of the bladder, the stretching of the bladder ruptures the veins. So that is the cause of the hematuria. Right, great. Come, keep asking doubts. I'll ask them generally when the segment is over. I'm not averse to doubts. I hope you keep asking me doubts and I'll be the happiest. Chalo. We'll start prolapse in pregnancy, guys. So when the person has prolapse in pregnancy, it can present for the first time in pregnancy, which is rare. Usually what happens, a woman has prolapse and she conceives. Then what happens to that? That's what is the major discussion of this topic. So what happened that this woman had delivered a baby, let's say 5 years back. It was badly conducted labor in a village and she has a prolapse. She has a second degree, third degree prolapse. But in spite of prolapse, she can conceive. Yes, sometimes the cervix is so hard and keratinized that she may end up in an infertility also. But quite a few of them, they easily conceive. Now, when a woman conceives, that what happens to the pregnancy and delivery, that's what we're discussing. So prolapse that existed before pregnancy may become better or even reduce by the end of second trimester. I'll try to explain how. You know what happens? See this. The cervix is, this is the vaginal outlet and the cervix is outside the vagina and there is a uterovaginal prolapse. But what happens now, she's got pregnant and slowly the uterus will increase in size. When the uterus goes into the pelvis, when it becomes bigger, can you see? The uterus gets pushed inside and the prolapse becomes better. It's not that it's getting healed. It's just that the uterus becomes bigger and the cervix get pulled up. You're not healing the prolapse that way. It's just that it's just gone up. That's all I'm trying to say here. So that is what is the behavior of prolapse. But it may come for the first time in pregnancy also, and that it presents most commonly, if it is presenting for the first time in pregnancy, most common presentation in third trimester. It presents in the third trimester. All right, guys. Chalo. So sometimes these prolapse can end up having an abortion. You have to look at the cervical lips here, guys. See, uterus, baby, cervix is outside. These get progressively edematous because they are hanging outside, and as the baby gets into the pelvis and the uterus becomes bigger, this cervix gets compressed from the sides by the vagina, and that compression, can you see here, that compression is going to reduce the venous return, and that's why the cervix becomes so badly congested. It gets even more thicker and bigger, and when it gets very badly congested and thicker, then that thick cervix, the congested cervix, edematous cervix, will then press the arterial supply. Because it's got so badly distended, the arterial supply will also stop. So that causes ischemia to the lower segment of the uterus. So yes, reduced venous return, like I said, there is worsening of the edema, and that causes the arterial supply to lower portion of the uterus also reduces, and that causes ischemia of the uterus and even fetal death. So that can happen in a case of prolapse in pregnancy. So treatment is to give measures to reduce the edema. So how do you reduce the edema? You can, the mother is lying down straight like this, you make keep her a little head down. You can keep her in a little Trendelenburg position. So the edema reduces. So giving this little head low kind of a position while resting, that is going to reduce the edema of the cervix. Then you can also do a measure of eccriflavin glycerin packing, AG packing. All you interns have done that, I'm sure, in your gynae postings. We when a woman with prolapse comes, even without pregnancy, a lot of patients who come to with prolapse, third-degree prolapse, they have these decubitus ulcers. So your residents will teach you that you have to reposit the prolapse with the eccriflavin glycerin packing, so that the eccriflavin is a local antiseptic and the glycerin is a hygroscopic agent. It's going to take out the fluids from the cervix. So packing will help, and after around 2-3 weeks later, 1 month later, you see the ulcer actually heals up, because once you push the uterus back inside, the venous congestion reduces and the fresh blood will come and heal these areas. So it is a patient treatment of this decubitus ulcers by eccriflavin glycerin packing. The same eccriflavin glycerin packing can be given to a woman who is pregnant also. I have written all that here. And pessary for the relief in symptoms, because if you put a pessary, see the cervix is now very edematous. I'm trying to make thick lips here, and there's a baby here. So what you can do, you push it back inside, you know, with the pessary like this. You push it here inside, and this pessary is here. So when this pessary is applied, this pessary will make sure that the patient is having a relief in the symptoms, and when the cervix goes up, the venous return also increases. The venous return increases and the congestion reduces. So in addition to giving the woman a head low position, Trendelenburg position, you can also give the pessaries. How do you know the pessary is adequate? Favorite MCI question and INICT. INICT and MCI questions, they are always almost on the same topic. So yes, the pessary which is comfortable for the patient is applied, and once it is applied, the woman should not have pain. And the best test to know that is adequate, that the woman strains and the uterus does not come down. So that's how we know that the pessary is adequate. That's what I have written here. So we can also do the modified Gillen surgery for pulling up the uterus inside. So I'll try to show you with my hands. Suppose you imagine me as the uterus and my arms as the round ligament, and this round ligament is going to the deep inguinal ring and to the inguinal canal like that. So this causes anteversion of the uterus. Now there's a prolapse. So this round ligament is loose and the uterus is hanging out. So this round ligament which is so loose, so you will plicate it, you will shorten the round ligaments. When you shorten the round ligaments, uterus comes back. Okay, the uterus will come back because you plicated, you have shortened the round ligaments. So that is what is known as the plication, and then you hitch the round ligaments to the rectus sheath. You didn't understand much. We'll show you with a picture. So this is the round ligament here. See here, this is a round ligament here. It goes to the deep inguinal ring, comes to the vagina in front. All right. So this round ligament, we shorten it. See, the uterus is hanging with these two ropes, the round ligament. So we shorten this ligament, plication is the word. So when you shorten it, it'll pull up the uterus. So one is to shorten the ligament, and two, you hitch. See the round ligament here, you hitch it to the rectus sheath. The anteabdominal wall has a rectus sheath. You hitch it to that. So it'll pull the uterus up, and that will give a relief in the symptoms of prolapse. All right. And in labor, there can be major problems. The cervix is so hard and edematous that it may not open properly during labor. Sometimes what we do, then we keep putting our fingers onto the cervix and helping it dilate. Yes, manually we help the dilatation of the cervix. So if you look at this baby's head, it is, suppose my I'm trying to show you my fingers like the cervix here. This is the head of baby, and the cervix is so hard that it is not dilating. You know, this is the fully dilated cervix and the head comes out. So now if the cervix is not fully dilated, see, the cervix is, let's say, only 6 centimeters and it is not dilating. So what we do, we keep putting our fingers and trying, because it's a hard cervix, we keep trying to iron the cervix, and with that, you know, it may get slowly dilate it, and we keep pushing it also slowly we stretch it with our fingers gently. Don't, again, no brute force. See, obstetrics is a lot of physical work again, but not brute force. So you do not tear the cervix. You gently keep doing this, and with your fingers slowly, you may push the cervix behind the head of the baby. And that's what we do in the labor room. So many times these women will deliver, but sometimes it does not happen. Whatever you do, it does not happen. So we have to cut the cervix. So that is what is known as a Duhrssen incision. So you see the cervix is not now completely, it is not getting completely dilated. The head is still inside. So you can, I'm trying to show you normal cervix here. So you have to make incisions here. You have to make incisions here. So at 10 o'clock and 2 o'clock, you make the incisions. So Dührssen incisions. So this is something like this. I've made the diagram before itself. So this is the head of the baby, and this is the cervix, which is not dilating enough. So you cut at 10 o'clock and 2 o'clock, the cervix opens, and you can give the patient a normal delivery. Right, guys? So that's about the discussion here today. And I thought we'll discuss a few peculiar, some conditions which keep coming into our obstetrics unit and in the labor rooms. But yes, all of them can be disasters, but if properly managed, we can give a comfortable mother and live baby. So what are you asking me? How is the pessary adequate? Pessary is adequate because once you put the pessary and then the mother pushes, the uterus does not come out. Okay, suppose she is around second trimester or third trimester of a pregnancy and the uterus is coming out and the cervix is hanging out. You push a pessary and the uterus goes inside. It stays inside. How do you know it is adequate? That when she strains, the uterus doesn't come out. Even in a normal prolapse, in a woman who is 75 years and she's got a prolapse, you put a pessary, and that's the pessary test. You tell her to push, it doesn't come out. That's what is adequate pessary. Okay, Shirodkar sling. Now, we are not talking about a non-pregnant woman. My friend, Shirodkar sling surgery is done for nulli. Please read the app. We have discussed that in detail. Maybe all of the lectures are now getting uploaded. I think most of the gynae lectures are there. Obstetric lectures are also getting uploaded. And we'll be telling you about all of this. But those who've seen my other lectures, you will know that sling surgery is done for nulliparous prolapse. So when the uterus is hanging outside, I'll just try to show you with the, I'm talking about a nulliparous prolapse in a girl who's, let's say, 15, 16 years. So this is the sacrum here, this is the uterus here, and the uterus hanging out in prolapse like this. So when the uterus is hanging out in prolapse like this, you take a rope, tie it to the uterus and pull it inside. Tie it to the uterus and pull it inside, and tie that rope to the sacrum, so the uterus doesn't come out again. So this is known as a sling surgery for a nulliparous prolapse. Definitely not in a pregnancy. I'm not going to do that major surgery in a pregnancy. Can do if you're a maverick, but I've just told you one surgery during pregnancy, and that is a modified Gillian surgery. Spontaneous abortion, because the cervical lips are too thick, and those thick lips will become even more edematous because the patient is having a hanging cervix. When the cervix is hanging out, I'll try to show you with this demonstration. Vagina, uterus. Can you see that? Now the uterus is hanging out like this, out of the vagina. When the uterus is hanging like that, so this vagina, can you see this vagina is preventing the venous return of the uterus. So the cervix gets congested. See, arterial flow will go because artery is 120/80, but the venous pressure is lesser. And with this compression of the vagina, the venous flow may reduce. That's why the cervix keeps getting edematous, especially in pregnancy. Now, these are edematous lips, and edematous lips means venous return will reduce even further. They'll become even more swollen. Then they become so swollen that the arterial supply also gets compressed by the swollen cervix. The descending cervical artery, descending branch of the uterine artery, they will get compressed. And when they get compressed, the blood supply to the uterus stops. That causes ischemia and death of the baby. It's there, Sudha. It is there in this lecture already. You can rewind and play it. You'll get it. Okay, please take sessions for practicals, OBG, including examination, Viva, question spotters. Yes, man, why not? My team is looking at all of this and we are doing it. We're going to do all of that. Yes, definitely. Spotters, why not? We'll do spotters session for my final year students. Definitely. My most favorite topic. We'll do that. Chalo. Malika, thank you. Thank you. And love to all of you guys who are here and those who could make use of the lecture, fine. And I hope you keep sending me your queries on this. And like I said, my team will always remind me there are some queries which if I am missing, they'll remind me to answer here. Alright guys, keep coming back for more. We're going to be meeting for obstetric hemorrhage next. So that's after a couple of days. Bye bye. See you around. Oh, I could not disconnect because I saw Sudha Pasamanta is not happy with me. He still has a question. Right, my friend. Duhrssen incision in one's place. Duhrssen incision is cutting the cervix. Okay. Look at this cervix. See, this cervix is not dilating properly. When it is not dilating properly because it's a hard cervix. So what do? You can cut the cervix. You can snip the cervix and the cervix opens up and the baby comes out. Obviously, after the baby is out, you have to suture that. Duhrssen incision is given for allowing the baby to come out. You have to again suture the cervix to repair it. That's the last desperate measure to get a baby out of a cervix which is not dilating. All right? Yeah. Right.